So shock. Basically, it's a syndrome. Oh, we've heard that before, right, for test 3. It's not a disease process in of itself. It's a syndrome where you have decreased tissue perfusion. So, meaning what? Blood is not getting to all the tissues. If blood's not getting to all the tissues, you can't have cellular metabolism happening right. That's where you get like ischemia. Another way to say it, it's an imbalance of the supply and demand. So for whatever reason, there's decreased tissue perfusion. So the supply for oxygen and nutrients is less than the demand for oxygen and nutrients. And we lead to this anaerobic metabolism, right? So this is when your body starts breaking things down without oxygen. Anaerobic means no oxygen. So if you have anaerobic metabolism, that's toxins that build up in your body. That's what helps shut down all those organs, and you get that lactic acid buildup. Why do you care if there's toxin buildup and lactic acid buildup? What's going to help diagnose shock? Oh my God. All right, I'm going to quickly go over this because we'll get to specifics. Table 67.3 is all of them. But for all types of shock that we talk about, in general, these are the things that we use. History and physical, obviously. Past medical history, past surgical history. Blood studies, we talked about the lactate, right? Because for all types, they're going to have lactic acid buildup because they're in that anaerobic metabolism. We can do things like an ECG, a chest x-ray, hemodynamic. This is just in general. So don't freak out too much because we're going to talk about them in specifics. But it's important to know, does any one study diagnose shock or differentiate between the shocks? No. It's a puzzle we're putting together. We need to look at all the pieces. So cardiogenic. What is cardiogenic? It can be systolic or diastolic. So what causes it? Systolic or diastolic? What is your heart doing during systole? Contracting, right? And it so it's contracting. What is it doing with the blood? Pumping it forward. So if they have systolic dysfunction, what do you think it's not doing? Not pumping, right? So if what you're supposed to do normally, this is why I always say you got to know normal to know abnormal. If it's supposed to pump the blood forward and it doesn't, it's a systolic dysfunction. What do you think happens to your cardiac output if you're not pumping blood? Decreases. These are things like an MI. You get hit in the chest really hard. Hypertension. All those conditions that we talked about already. Oh, if I have an MI, I'm not pumping the blood forward. If I don't correct that MI, not only am I at risk of dysrhythmias, I could go into shock because I don't have enough cardiac output. I don't have enough O2 and nutrients to meet the demands of my body. My supply is going down. What happens during diastole? What's your heart supposed to do? Relax, right? So if you have a dysfunction, your ventricles aren't relaxing. If they don't relax, can they fill with blood? If they don't fill with blood, can they pump the blood out? No. What happens to your cardiac output? It decreases. So again, if we don't have cardiac output is blood being pumped out to your body. That blood carries oxygen and nutrients. If there's no oxygen and nutrients being carried out, you're going to go into shock, or you have the potential to go into shock. So things like ventricular hypertrophy, right? If that left ventricle is all thick, like someone in heart failure, the ventricle can't fill enough with blood to pump out. Other things that can kind of be a combination of systolic and diastolic, dysrhythmias, stenosis, tension pneumo, right? The tension pneumo that we talked about, kind of talked about, and you listened to on the lecture online. It's, when you have that tension pneumo and that lung collapses and it causes the pressure, it pushes pressure onto the heart, and that's going to decrease cardiac output. So how do we diagnose it? The lactate, we already talked about that. And things that are related to the heart. Troponins, chest x-rays, EKGs, echoes, all those things Miss Lewis already beat into your head. So if the problem is I'm not pumping out enough or I'm not relaxing to get enough, then I have to treat that, right? Because as soon as I increase my cardiac output, my tissues are going to get nutrients, my tissues are going to get oxygen, and then I'm going to come out of that shock state. So it's all about the cardiac output. Do these patients have enough fluid in them? Yeah. They're not deficit in fluid here. So it's not that, like, when we're going to talk about in a second, hypovolemic, where there's a loss. The fluid's there, it's just not being pumped out for whatever reason. So early on, what does your heart do to try to compensate? Increase. Your blood pressure drops. But more importantly, if we're thinking that this is kind of low cardiac output, we're looking at like signs and symptoms of heart failure, right? That's basically what's happening. The heart is not pumping out enough, blood, so the cardiac output's low. So if we're thinking heart failure, what are the things that we saw in heart failure? Like, because it's mostly the left side, right? We said mostly left side. Maybe in my notes I have it. There you go, mostly the left ventricle. So if it's mostly that left side, what is left-sided failure? What signs and symptoms do we see with left-sided failure? Crackles. Lung issues, right? So if I have a patient that got hit in the chest, they got in a car accident, the steering wheel hit the chest, and they have some bruising, but they come in and they're doing okay, and all of a sudden I listen to them, and they're kind of wet, and their heart rate's up, maybe their urine output drops, right? Because if blood is not pumping out to the organs are shutting down. So if no blood to the kidneys, what's happening to the urine output? It's going down. If no blood to the brain, what is the patient going to act like? Restless, confused, anxious. So I have my patient that was in a car accident that I thought was stable, and I thought they were doing okay, and all of a sudden I notice, they have bruising over their chest, and they sound kind of wet and crackly, and they're acting anxious. Oh crap, could they be like having some decreased cardiac output? Are these early signs and symptoms that they could be going into cardiogenic shock? Yep. So I'm going to be like, hey doc, I think we need an x-ray. I think we need an EKG. I think we need an echo. We need to see what's going on. Which one? Anxiety, confusion, agitation, decreased renal perfusion. So they have oliguria, right? Decreased urine output, sodium and water retention. So hypovolemic, it can be an absolute hypovolemia or relative. Absolute means they lost fluid. It's gone. It's either because they hemorrhaged, they're not stopping with vomiting and diarrhea. It could be like diabetes insipidus or a diabetic who's in like ketoacidosis and that urine output, they're just dumping urine. So they lose some kind of volume. Huh? The VD, vomiting diarrhea. Yeah. Vomiting diarrhea. So diabetics like the diabetes insipidus or a diabetic who's in ketoacidosis, they're dumping urine, right? So are they having massive fluid loss? Someone who's in a car accident and maybe is internally bleeding, massive hemorrhaging. Relative hypovolemia means they're third spacing. So they don't lose the fluid. They're not peeing it out. They're not vomiting it out. They're not hemorrhaging. Their fluid is just going from intravascular to extravascular space. So like burns. So am I going to treat someone with absolute hypovolemia the same way I treat someone with a relative hypovolemia? No, because with a burn, we have to push those fluids back into the intravascular space. All right, if you guys remember from 3, what's happening with burns is that their capillaries become permeable and they're just losing fluids. If I just keep pumping fluids into them, they're just going to keep losing into their extravascular space, right? So I've got to do things like albumin that pulls fluid back into the space. I'm not going to pump them full of fluid because that's not going to work for them. But I'm not going to, for an absolute hypovolemia, they need fluid. I'm going to pump them with a crap ton of fluid. But cardiogenic, did they have fluid loss? No. So is my goal with that to pump them full of fluid? No, because they're already having signs and symptoms of heart failure, right? So if I pump them full of fluid, what do you think I'm going to do to their lungs? Drown them, right? So again, your patients, you're not going to walk in for a test or for a patient and they're going to tell you, I am currently in cardiogenic shock. No, you're going to give a scenario that says your patient had an MI, your patient's leg got cut off and they're hemorrhaging, your patient's a burn. And in your mind, you've got to say, okay, this is the type of shock they're in. So I know they've got fluid, they don't have fluid, and how I'm going to treat them, which we're going to get to. But this is how I kind of want you guys to start thinking. So diagnostics, all that stuff we talked about. Hemoglobin, hematocrit, lactate, urine output, electrolytes. And the patient's response depends on the type of injury, their age, their health. Am I going to respond better than a 94-year-old woman? Yeah. I hope. God knows. Typically, when you have about a 15% fluid loss, your body can compensate. When you're getting to like close to 30%, your sympathetic nervous system kind of activates and is like, I'm going to help take over. But once you get to a greater more than 40% loss, that's when your autoregulation fails, and that's when you tend to go into like shock. So your body can compensate to a degree, right? We've all vomited, had diarrhea, GI bugs. We feel crappy during it, but we don't go into shock every time. We're able to compensate a little bit. But this will vary, like children and elderly are more at risk. So if you're dehydrated, what do you think is happening to your pulse? Yeah, is it a nice, thick, bounding pulse? No, it's weak, right? Because they don't have a lot of fluid in there. But it's beating really fast because it's trying to take the fluid it has and utilize it. So it beats real fast. They're probably anxious. They increase their respiratory rate. Again, cardiac output's low. but not because the heart's not pumping it out. The cardiac output's low because there's a fluid volume deficit in general. Urine output's going to be low. They can be cool and clammy. And again, this is kind of where you could maybe make yourself a chart, just like you made for bioterrorism, and say, what's my type of shock? What's the quick patho behind it? Is there a true fluid loss? Is it the heart not working? Whatever. And then what's the main signs and symptoms, and how am I going to treat it? Oh, dry mouth, pale skin. All right, so neurogenic. We talked about this in test 1. Oh my God, it's all coming together. It is, Morgan. All right, so causes. So remember when we had neurogenic, it was this massive vasodilator, right? So they had a spinal cord injury and they vasodilate because does the sympathetic nervous system, it kind of loses itself, right? So those blood vessels are just bloop. Now, do you still have the same amount of volume? Yes. So you just went from having volume in this kind of vessel to volume in this kind of vessel. So it's again, you haven't had a fluid loss, you just are vasodilating. So blood tends to pool in the vessels. So is this person going to be a candidate for pushing fluids? No, because they're not. What do we want to do? We want to vasoconstrict because the fluid's there. They're just vasodilated. So typically it's those spinal cord injuries greater than T5, so the head and neck injuries. Sometimes you can get it with spinal anesthesia or with opiates or benzos, too much. But normally when we with hypovolemic, the way our body compensated was to increase the heart rate, right? Even with cardiogenic, it's going to try to beat a little faster because it's not working as efficiently. But the difference with neurogenic, remember, is that SNS involved with this, their sympathetic nervous system? So they get bradycardia. So that's a big difference between those shocks. And they get hypotension. All of shock, with all shocks, your body is not getting the oxygen and nutrients needed. But it's caused by different things. And you have to know the cause to know how to treat it. So they get that temperature dysregulation that we talked about, dry skin, I can't say that word, decreased urine output, the poikilothermia. Oh, are we good? Okay. Anaphylactic. Anaphylactic is a hypersensitivity reaction. This also causes vasodilation. So mediators get released. They increase capillary permeability. So fluids shift from intravascular to extravascular space. So with neurogenic, they had a spinal cord injury. They vasodilated. Their SNS is not coming into play. So they get the bradycardia, and our job is to kind of vasoconstrict so that we can use the fluid that's already there, right? With anaphylactic, they're having some kind of reaction, right? So either they come in contact with it, they touch it, they inhale it, they ingest it, they inject it, something. Somehow they come into contact and they get this hypersensitivity reaction. So again, all these things we talked about, shocks, DIC, ARDS, they're all syndromes. So in order to treat anaphylactic shock, we have to treat the cause, right? Whatever the person's being exposed to. And people don't have anaphylactic reactions the first time they're exposed to something. You can't. It takes the second time, the third time, the 20th time to be exposed to it. Your body has to build up those antigens in order to even attack something. So the first time you get exposed to it, and depending on how sensitive you are, you'll build up antigens. The next time, you're either going to build up more antigens. Maybe you have like a little tickle in your throat. Or maybe you just got a little rash the second time. And the third time, you break out all over. Or in the fourth time, you go into like respiratory distress. And now, like by the 20th time, you're an anaphylactic. And that can even happen on the second time. It just depends on how sensitive your body is. But your body has to build up that sensitivity. So they get respiratory distress because their airway swells up. And it starts to bronchospasm. They get swelling of the lip tongue. If you ever have a patient that comes in and says, I was just eating a peanut butter sandwich and now my tongue is tingly. Christine and I had this in the ER the other day. My butt clenched a little bit and we threw like 3 meds at them right away. Like a lot of meds. Because you're afraid that airway is going to clamp down. Oh God, I forget I'm recording myself. So, yeah. All right. You get circulatory failure because you have that vasodilation. Sometimes they get a little flushing, itchiness, hives, but it's sudden. And they do get this kind of sense of impending doom. They're scared. They kind of feel like something is not right. I don't feel good. Like something bad is about to happen to me. It's okay. So in general, it's, the respiratory distress. What do you think of when you like have a bad, like allergic reaction to something? You get itchy. You get hives. You get a rash. All right. So sepsis, and we're going to talk about SIRS in just in a second. So septic shock, they have some kind of infection, right? So again, they're sick, they have some kind of infection, their blood pressure is not great, so the tissues aren't getting perfused. If the tissues aren't getting perfused, there's no oxygen or nutrients. They become hypoxic. So who's at risk? Age, right? Again, little babies and the elderly are more at risk to become in septic shock. Immunosuppression. So those that need reverse isolation, like your chemotherapy patients, that's why we do that. Because if they're undergoing chemotherapy and we walk in their room with a little, we have a little cold or virus, their body's going to kind of react more, right? Because they can't compensate as well. So they get sick and then they go into septic shock. Trauma, invasive lines. A big part of the time we don't know what causes septic shock. But obviously, if it's an infection, it's got to be some kind of bacteria or a virus or a fungi, or a parasite, right? Something's infecting the body. So the body is so again, in me, a healthy individual going to go into septic shock if I get a cold? No. Is a 94-year-old woman more likely, if she gets sick, to go into septic shock? Is a 60-year-old woman getting treated for chemo, with chemo for breast cancer more likely to go into septic shock? Yeah. So you have some kind of infection, and because you have risk factors, your body can't really compensate as well. Your blood pressure drops. You don't have that cardiac output. So body's response to some kind of microorganism is exaggerated. So they vasodilate, blood doesn't go, heart doesn't work as well. I'm just putting it, ooh, don't, okay. So we're going to go into this a little bit more when we talk about SIRS in the next lecture. So don't freak out too much. There's a lot of writing here. But basically you're going to see things like the low urine output, GI dysfunction. Your body's not getting perfusion. So everything starts shutting down. So again, it's your brain's not getting perfused, so you're going to be restless and anxious. Your kidneys aren't getting perfused, so you're going to have low urine output. Your lungs aren't getting perfused, they start to fail, develop ARDS. That's why we said, sepsis is the #1 cause. I'm not going to spend a lot of time, and it's going to be okay. I'm going to flip it. Everyone take a breath. All right. So obstructive, I like this. Hey girl, are you a pulmonary embolism? Because you're making me breathless. So there's physical obstruction to the blood flow. So again, we have some kind of decreased cardiac output, decreased tissue perfusion. All of these are because blood flow is not happening. But again, is this someone that I'm like, they have a PE, so they have a pulmonary embolism. Is blood going through the lungs, right? That's where ARDS came into play, or respiratory failure, right? It's not going through the lungs. It's not participating in the gas exchange. It's going back to the heart, not perfused, and it's getting pumped out to the body, no oxygen or nutrients. So is throwing fluids at this patient going to be appropriate? No. Just like anaphylactic, with anaphylactic, we treat the cause. With obstructive, we treat the cause. And it's things like a cardiac tamponade, the tension pneumo that we talked about again, where the lung collapses and it causes pressure onto the blood vessels. That's an obstruction, right? We might see the clinical signs and symptoms like a deviated trachea, absent breath sounds. You may need to get an x-ray or like an echo if it's, we think that it's something with the heart, like a tamponade. Clinical manifestations, you might see jugular vein distension, right? Because blood is kind of backing up. So you see those neck veins distended. You might see a different in pulses. Pulses up here are bounding. Pulses down below are like 1+, and pulses neck and above are 4+. That pulsus paradoxus, because blood is being pumped here but not getting out to the rest of the body. And they could even go into cardiac arrest. These patients, again, just like anaphylactic, this is sudden and fast, and you have to treat right away. Deviated.
That's an obstruction still because it's.
Yeah, because with it like a tension pneumo, the lung collapses, right? And you have all that positive pressure inside the chest, and all that positive pressure pushes up against the other side. Excuse me, it's normally right to left.
Okay, so that would be considered.
So it pushes all that, and you have a blood vessels like this normally, and because it's being pushed, now your blood vessel gets closed off. So the worse the tension pneumo, the worse it is. So you can have like a cardiogenic shock because a tension pneumo is pushing on it, but not causing complete obstruction. So it's decreasing the cardiac output. But if you have a tension pneumo that's not corrected, it can cause complete obstruction. So this is a little chart in your book, kind of talking in general, everything that's happening. And like you'll see with most of this, normally the sympathetic nervous system's activated, right? Because it's helping, it wants to preserve that blood flow. It wants to get that blood out to the tissues. Because if it gets blood out to the tissues, it's getting oxygen out to the tissues, it's getting nutrients out to the tissues. And these are all your vital organs: lungs, heart, kidneys. So this is in general how we take care of these patients. There is a table, I think it's 67-7 in your book. Quick diagnosis, right? Do we want to take our time diagnosing anaphylactic shock or obstructive shock? No. ABCs, right? Always ABCs. Do they have an airway? Are they breathing? Then I can worry about my circulation. And if the problem is no perfusion, what do we want to do? Increase it. And protect our organs. Just like when we talked about the MI in the heart, that if it doesn't get perfused, it dies off, right? Bless you. Ischemia, that's the same thing that can happen. We don't want the kidneys to die off. We don't want the lungs to develop ARDS and kind of get fibrotic and die off. So we've got to protect those organs. How do we protect the organs? By increasing perfusion. How do we increase perfusion? Diagnose it quickly and know how to treat it. So we expand volume. Do we expand volume with all shocks? No. But if we do, what are the shocks that we do volume? Hypovolemic, septic, and sometimes with anaphylactic we can give fluid, even though they're vasodilating. Remember, they're pushing those fluid into the extravascular space, so we do sometimes give them fluid too. But definitely hypovolemic and septic. It's typically normal saline. We can give blood. We want that CVP. So remember, oh God, we're going back to test 2 again. That central venous pressure. We know that their cardiac output is good if their CVP is good, right? If we have a CVP of 8 to 12, then we know that we're getting enough cardiac output out to the body. Then we know we're getting enough tissue perfusion. What's my rule with feeding? Do it. That's always my rule. So we want to start feeds right away.
Is that meant to be within the first 24 hours?
Yes.
Okay.
Why do we use drugs like dopamine and dobutamine? What do?
Increase the heart rate.
How?
The sympathetic nervous system.
They don't. Tell me. Yeah?
I don't know.
Yeah, I see the squeezy squeeze. Yep. Increase contractility, right? So they increase that contractility. So what shocks are they going to be good for?
Cardiogenic.
Sometimes like your neurogenic shocks, right? That you're vasodilating because your sympathetic nervous system isn't coming into play. So it improves, but it can be used in all of them. It can be used in anaphylactic. It can be used. It helps increase that contractility to increase cardiac output. If they increase cardiac output, we increase. Oh, I'm sensing the theme. Oh, there, I even wrote it. So we improve contractility, increase cardiac output, increase tissue perfusion. Sometimes we need to use vasodilators, which I know seems like a little in the opposite direction, right? So we're not going to use it if they're already vasodilating, but maybe with a cardiogenic shock, we need to vasodilate, right? They're having an MI, we need to open up those vessels. They're obstructive, we need to open them up to get that blood out. We have to be careful though. Remember we talked about that mean arterial pressure in test 1? You're like, oh crap, we still have to remember that stuff? Yes, you do. All right, so that mean arterial pressure, we want high, right? Because that mean arterial pressure means that we have enough pressure, your blood pressure is pumping enough to get blood to that brain. So we're not going to give nitro if that mean arterial pressure is too low. So it's got to be greater than 65 so that we know we have enough pressure to pump blood to the brain and to the other organs. And ABCs, right? We said patent airway. We always want that PaO2 above 60 with the lowest possible O2 concentration. O2 above 90. If we need to, we vent them. They're tired. Their bodies are working hard. Space care, we don't tire them out. Do we come in and feed them breakfast, change their clothes, get them up with PT, and have their family visit all within the first 2 hours of our shift? No, that's a lot. So we've talked about cardiogenic, right? I'm going to put it all up there. It looks like a lot. Let's just focus before you start writing, okay? What's wrong with cardiogenic? Is there fluid volume there?
Yes.
Is the fluid volume being pumped out? Either because the heart's not pumping it out or it's not relaxing to fill it, okay? So we've got to restore what? Blood flow. That's our main goal, is to restore that blood flow. So all the things you talked about in test 2 that you already know about, taking them to cardio-cath if it's an MI, monitoring hemodynamics, right? Doing all these things, the circulatory assist, the IAB, right? The intra-aortic balloon pump to help increase cardiac output. All these things that you kind of, thrombolytic therapy, if there's a clot in there, we're going to break it up. All those things, this is all test 2 right here. If we improve that, if we treat it, then we're going to improve cardiogenic shock. We might need to do drug therapy, all the drugs we talked about in test 2. And again, is this somebody that we're going to throw fluid at? No, because their fluid volume, there's no deficit. They just can't pump it out. So we have to find out why they're not pumping it out and fix it. You could just write C test 2. Okay. So we're increasing that cardiac output by either helping systolic, helping pump it out better, or helping the ventricles relax so that they get more preload to pump it out. All right, moving on. Nobody freak. All right. So with hypovolemic, is there a fluid volume deficit? Yes. Okay. So, this table 67.7, I think. What if there's a volume deficit? What do we need to first do? Stop the loss. If they're hemorrhaging, stop the hemorrhaging. If they're having massive urine output because they're in diabetes insipidus or they're, a diabetic in ketoacidosis and they're just dumping urine, we've got to treat that underlying cause. We have to treat why, or if they're having massive vomiting or diarrhea, we've got to kind of stop that and replace circulatory volume. So start giving fluids. What kind of fluid are we going to give? Oh God, she's asking stuff from test 1. Isotonic, right? Because isotonic doesn't push fluid in or out of the cells. It just fills that the intravascular space. So it's not worried about pushing, because are the cells dehydrated? No, we've just lost volume. So we're not worried about pushing fluid in or out of the cells. We just want to fill up our intravascular space. So isotonic. We can use blood, pressors, FFP, surgery to stop the bleeding if it's internal. Septic. So, like I said, there's a sepsis alert protocol. I believe it's figure 67.1. If I'm wrong, let me know. Or e-figure. I'm sorry, it's an e-figure in online. All right, there's going to be lots of writing up here too, but chill. That's okay. All right. So again, the septic shock, they're having some hypersensitivity reaction, right? Their body is reacting to some kind of organism. They're either reacting to some kind of parasite or bacteria. Again, we want to target that CVP to be 8 to 12. And we're going to get more into this when we talk about sepsis in the next lecture. We're going to be, obviously, getting antibiotics with cultures. So we culture everything, right? If we don't know, if this patient comes in and they're sick and their blood pressure is low, they don't have good cardiac output, they have a high fever, they're sick. And we're going to start culturing. We're going to get wound cultures, blood cultures, urine cultures. You'll see someone that comes into the ER and they're kind of confused, high fever, we don't know what's going on. That's why you guys saw in the ER, they go ahead and just get everything, and then they start them on a broad spectrum antibiotic, and then once the cultures start coming back, once we get that blood culture, once we get the urine culture, then we can hone in on the infection. But we kind of get everything, broad spectrum, and then hone in. And these are started fast. As soon as they come in and they're, not doing well, we get all these cultures and they're started on a broad spectrum in the ER within that first hour. These are the patients. This is why we put everybody on H2 blockers in the hospital, because we don't want those stress ulcers. Because is that a source of infection for them? Yeah. So we don't want our compromised patients that are in the hospital that are at risk for infection to get a stress ulcer, get it infected, and then go into shock. Oftentimes they need DVT prophylaxis because they're laying in bed. They need to be on isolation if they're at risk for infection. All right. central venous pressure. So neurogenic, that's why we say when we get someone who has had an injury that we suspect might be a spinal cord injury, the first thing we need to do, when we talk about ABCs, what's part of that A? Stabilizing the C-spine, right? When we talk about trauma triage and ABCs, A, B, C, D, E, and primary and secondary survey, we talk about, stabilizing that C-spine. And again, neurogenic is a little bit different because unlike the other shocks where the body tries to compensate, because that SNS activates, the sympathetic nervous system activates itself, and it's trying to compensate to increase perfusion, to help protect those organs. Well, with neurogenic, they don't get that SNS activation. So they have different symptoms. So they're going to be bradycardic and hypotensive. So we're going to treat that. Vasopressors, right? The dopamine, the dobutamine, kind of increase that contractility. And again, is this somebody that we throw fluids at? No, because they didn't lose fluids. Unlike septic shock where there's kind of fluid loss. Unlike hypovolemia where there's obvious fluid loss. These patients did not lose fluid. They just have this massive vasodilation. And remember, because they're vasodilating, they're at risk for hypothermia.
Is it hypo or hyper?
Hypothermia. Anaphylactic, we want to treat the cause prevention first, right? How many of you have kids at schools that are like peanut-free schools? It's annoying. I can't send my kid a peanut butter sandwich. But if you have a couple of kids that have high allergies, there's lots of prevention. You teach them to avoid whatever is causing it. Epinephrine and Benadryl are your drugs of choice. So that's not something we mess around with. If we have someone that comes in and says, I ate some oysters and my tongue started tingling, or I have this rash, or I'm working really hard to breathe, we're going to throw a large amount of epinephrine and Benadryl at them. ABCs, what are we going to worry about with them? Airway, right? They go into respiratory distress. Their airways will clamp down. And this is why we always get a little concerned, because these patients, once their airways clamp down, we can't get an ET tube down them either. Or it's very difficult to get an ET tube down because their airway has gone from here to here and it's just spasming. So that's why we are going to treat fast and efficiently. If we see that they're going down the tube and they're not doing well, sometimes we will prophylactically intubate before they get too bad. Because once we have the tube in, then we can secure that airway and be in control. We'll use fluids and anaphylactic. And sometimes some IV corticosteroids. And then last, obstructive. Again, early recognition treatment. Fast. So, if it's a tamponade, a tension pneumo, we're going to decompress. That's when we use that needle decompression. That's why we have that. If it is pulmonary embolism, we start thrombolytics. If there's a mass, like a superior vena cava syndrome, then we're going to remove the mass. Mm-hmm.
Do you have to worry about like compartment syndrome after decompressing and having obstruction?
It doesn't happen very often. Do you mean like, give me an example.
Complications from like if there's obstruction then you like do the laparoscopy.
You remove the obstruction?
Yeah, you do that and then you worry about the acidic blood flow or
No, no. Because if you don't do it quickly, your patient's going to die. So this is done, I don't know how to say that nicer, but it is done like fast enough that it's not like an AFib where they could live with it for a month and then we have to worry about it. This is like hours. You know, someone with a PE, they know right away. I can't, like, I just walked across the room and now I can't catch my breath. I'm gonna go get seen. I get a, x-ray with that PE. I'm getting treated. It's within a few hours that it's happening. It's not over days or anything else. Your body doesn't even have time to kind of decompensate, if that makes sense. So. All right, I'm gonna do this fast because we've beat this with it. I was gonna say, I always make the expression wrong. Beat this with a dead horse, but you wouldn't use a horse.
No.
Like
beating a dead horse.
beating a dead horse. Thank you. I never use it right. At least you're all paying attention. All right. So, I have been working out, y'all. So, ABCs, onset, health history, right? Nursing diagnosis. It's all the stuff we already did. It's okay. It's really just an extra slide. I promise it'll be okay. I promise. Okay, yeah. They can have, obviously, nursing diagnosis, decreased peripheral tissue perfusion, anxiety, organ ischemia, all the stuffs we talked about. Planning. Again, all the stuff we talked about. What are our goals? We want to have good tissue perfusion. We want to have a normal blood pressure, because if we have a normal blood pressure, then we know our tissues are getting perfused. We want to have normal organ function, so we want to have good urine output. We want to be competent, not confused or restless. And we don't want to have any long-term complications. We don't want to develop ARDS. We don't want to go into renal failure, which Miss Lewis is getting ready to discuss with you. And then, again, this is all kind of what we've talked about. We're identifying at-risk patients. We're helping prevention. So if it's anaphylactic, they're carrying their EpiPen with them. They know what they're allergic to and they avoid it. If they're like septic, we're gonna, those patients that are immunocompromised, we're gonna put them in isolation. If it's, that's why we treat MI so fast. So we don't go into cardiogenic shock. And then all of these things you guys should be able to fill in yourself. What are these subtle changes that we're going to see? Decreased urine output. What's going to happen in their skin? And we always eval their response. If you're doing something and it's not making it better, try something else, okay? Sometimes it does take a little bit for things to kick in. But that's why we're not going to throw fluids at a cardiogenic patient, because it's not going to make them better. So if maybe you misdiagnosed, or maybe you're like, we're throwing fluids on this patient and they're getting wetter. Is that going to be a red flag to you to be like, you know what? This is not working. I need to reevaluate what might be causing this. Eval. This is how we know we've done a good job. So ECG is normal. Everything's within normal or baseline. Temp's normal, right? So they're not septic. They have warm, dry skin. Their urine output is 0.5 mLs per kilo per hour. 0.5 mLs per kilo per hour. Respiratory rate normal. Again, we want that MAP, the mean arterial pressure, will be greater than 65 because that means that we have enough pressure to perfuse the brain. We want that central venous pressure to be 8 to 12 because then we know that the heart is pumping out enough blood to the tissues to get perfused. All right. So assessing a patient in shock, the nurse recognizes that the hemodynamics of shock include what? Normal cardiac output in cardiogenic shock? Does anybody like this answer? Good. What is it? Decreased, okay. Increased central venous pressure in hypovolemic shock? Does anybody like this answer? No, why? What is it? Yeah, the CVP is decreased in hypovolemic. That's why we want it to increase. Whoa. Increase in systemic vascular resistance in all types of shock. Not all of them. Which ones is it increased? Cardiac and hypovolemic. Your neuro, your anaphylactic, that's when they kind of vasodilate, right? So is that resistance there? No. Variations in cardiac output and decreased systemic vascular resistance in septic shock. That's right. It's the only one left. All right.
You said SVR will be increasing hypovolemic?
Yeah. Because remember, they're not vasodilating.
They just,
Yeah. All right. Nurse is caring for a critically ill patient. The nurse suspects that the patient has progressed beyond the compensatory stage of shock if what occurs? Increased blood glucose, increased serum sodium, increased calcium, increased potassium. How many want A? How many want B? How many want C? How many want D? And nobody picks anything? Okay, we're going to do it again.
I like B because the sodium retention, you mentioned that.
All right, so who wants A?
Yeah,
Who wants B?
I'll take B, I'll go just because I didn't answer.
Who wants C? Who wants D? Where are my D people that were there before? Katie, you should have stuck with it proud.
No, I raised my hand for like 3 of them.
It's the potassium. What's happening to the cells as they're not getting oxygen and nutrients? What are they doing? Dying. When the cells die, what gets released? Okay? So, with sodium, you do retain a little sodium, but you're still compensating at that point. And when you start decompensating, you have cell death, right? And that's the whole point of why we teach about shock, is because decreased tissue perfusion leads to cell death. When cells start to die off, they break open and you have potassium released. The nurse is caring for a patient in septic shock. Which hemodynamic change would the nurse expect? Increased ejection fracture, increased mean arterial pressure, decreased central venous pressure, or decreased systemic vascular resistance? Who wants A, B, C, D? It's D. Yeah. So typically you have decreased central venous pressure more in hypovolemic and obstructive shock because it's preload. This one's tricky. It is not totally wrong. It's just not your best answer. Again, these aren't meant to freak you out. They're typically way harder than what you see. All right? But what I would do is, like I said, I'm going to go ahead and stop the recording.